Hi friends, today I will talk about a urine analysis which is done with the dipstick, that is dipstick urinalysis. First is the disclaimer. Caring Dogs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only, and this information should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention and treatment of medical illnesses. There is no endorsement for any brand or a company. Urine dipstick test. It tests the urine using a special strip of paper that is dipped into a sample of urine. The result is available almost immediately, so it is also called rapid urine test. It is rapid semi-quantitative assessment of the urine characteristics on the series of test pads. The various parameters which are analyzed are specific gravity, pH, protein, leukocyte esterase, nitrite, heme or blood, ketones, glucose, bilirubin and urobilinogen. First, let us discuss about how we should collect the urine sample. The First of all, we should clean the urinary opening with sterile wipes. It is important to get rid of any bacteria on the opening that may contaminate our urine and invalidate the test. If you don't have a sterile wipes, we should use soap or warm water to clean the area. Women should spread the labia and clean the area from front to back. Men should clean the tip of their penis before performing the test. The collection should be freshly voided. It should be midstream sample, clean catch, and should not be the first morning specimen. This test or sample should not be collected following the strenuous exercise, after trauma, after sexual intercourse, during febrile episode, and during menstruation. First parameter is the specific gravity. Normal specific gravity is 1.002 to 1.035. It measures the kidney's ability to concentrate or dilute the urine. It is directly related to urine osmolality, that is solute concentration. The specific gravity of the urine is decreased when it is less than 1.002. It shows inability of the kidneys to concentrate the urine, and it is seen when patient drinks a lot of water or patient is given high amount of IV fluids, that is excessive hydration. The patients with kidney damage like nephrogenic diabetes insipidus, acute glomerulonephritis may have decreased urine specific gravity. Fixed urine specific gravity indicates hydration or relative hydration, and it is seen in end-stage renal disease or chronic kidney damage. The specific gravity of the urine is increased when there is highly concentrated urine with high solute level is passed. Patients with dehydration, kidney failure, liver failure, and many more conditions may have increased urine specific gravity. Isothermiuria is when the specific gravity of the urine equals that of the plasma, that is 1.010. It indicates chronic tubulointerstitial disease. Coming to the urinary pH and factors affecting it. Normal urinary pH is 5.5 to 6.5. It can range from 4.5 to 8. Kidneys, they regulate the acid-base balance to maintain the normal pH. Factors affecting the urinary pH are high urinary pH, that is alkaline urine, is seen in vegetarian diet, patients who consume citrus fruit, or when there is systemic alkalosis. Certain drugs like amphotericin B, acetazolamide, renal tubular acidosis, urinary tract infection, they contribute to high urinary pH. Low urinary pH, that is acidic urine, is seen in conditions with high protein diet intake, patients who consume cranberries, or when there is systemic acidosis. Diabetes, starvation, diarrhea, malabsorption, and certain medication like certain medical condition like phenylketonuria, renal tuberculosis, they may show Low urine pH. Normal daily protein excretion should not exceed 150 mg per 24 hour or 10 mg per 100 ml. Proteinuria is defined by the production of more than 150 mg per day with nephrotic syndrome producing more than 3.5 gram per day. Dipstick urinalysis detects proteins with bromophenol blue indicated dye and is most sensitive to albumin and less sensitive to Bence-Jones proteins and globulins. Trace positive results are equivalent to 10 mg or 10 mg per 100 ml or about 150 mg per 24 hour, the upper limit of the normal. Renal proteins or true protein elevation is seen in renal condition like increased renal tubular secretions, increased glomerular filtration like glomerular diseases, nephrotic syndrome, pyelonephritis, glomerulonephritis, malignant hypertension, cerebrovascular syndrome or cerebrovascular condition like benign hypertension, congestive cardiac failure, subacute bacterial endocarditis, functional proteinuria that is albuminuria is seen in fever, cold exposure, stress, pregnancy, eclampsia, congestive heart failure, shock, and severe exercises. Other conditions which contribute to increased protein secretions are orthostatic proteinuria, electric current injury, hypokalemia, Cushing syndrome. Drugs like aminoglycosides, gold, amphotericin, non-steroidal anti-inflammatory drugs, sulfonamides, penicillin, they also contribute to proteinuria. False positive results are seen with concentrated urine, that is when urine output is less than 2.5 liter per day, alkaline urine when pH is more than 7.5, trace residues of bleach and acetazolamide, cephalosporin, sodium bicarbonate. False negative results are seen in diluted urine when urine output is more than 5 liters per day or acidic urine when pH is less than 5. Protein excretion less than 150 mg per 24 hour is normal. 150 to 200 500 mg per 24 hour is functional proteinuria. More than 500 mg per 24 hour is significant proteinuria. 3 to 5 gram per 24 hour nephrotic proteinuria. More than 4 gram per 24 massive proteinuria. Most common cause is amyloidosis. Less than 30 mg albumin per 24 hour is normal. 30 to 300 is microalbuminuria. More than 300 mg is albuminuria, and more than 2200 mg is nephrotic albuminuria. Limitation of this test is microalbuminuria is not detected with dipstick testing. Macroalbuminuria may still have negative result if the urine is very dilute. Recent exposure to iodinated radiocontrast agent can cause transient albuminuria. Bence-Jones globule associated with multiple myeloma. Bence-Jones globulins are associated with multiple myeloma, lymphoma. Macroglobulinemia is not detected by dipstick urine analysis. So here we can see that when the urine dipstick per protein is negative, it means protein excretion is less than 10. When it is trace, it indicates protein as 15 mg per deciliter. 1 plus indicates 30 mg. 2 plus indicate 100 mg per deciliter. 3 plus indicate 300 mg per deciliter. 4 plus indicates more than 1000 mg per deciliter. Coming to the leukocytes, leukocytes are white cell count. It determines the presence of whole or lysed white cell in the urine, that is pyuria, which is by detected leukocyte esterase activity. A positive leukocyte esterase test correlates well with the pyuria. It is released by the lysed neutrophils and macrophages, and it is a marker of presence of WBCs. Concentrated urine impedes the WBC lysis. Hence, diagnosis may be missed in up to 20% of the cases if negative urinalysis dipstick is used to exclude the UTI. False positive results are seen when the urine is contaminated, Trichomonas vaginalis, drugs, foods that color the urine red. False negative results are seen with intercurrent or recent antibiotic therapy, especially the gentamicin, tetracycline, and cephalosporin, glycosuria, proteinuria, high specific gravity, and low bacteria count UTI, especially in the women. Coming to the nitrites, Nitrites in the urine are converted to nitrates. Nitrates in the urine are converted to nitrites by the enzyme nitrate reductase, which is produced by the gram-negative bacteria such as E. coli, Klebsiella. A positive nitrate test is a surrogate marker of positive bacteriuria. Positive test strongly suggests infection, but negative test does not exclude it. Positive predictive value is 95% and negative predictive value is 20 to 70%. False negative results are seen in drugs or foods that color the urine red. Certain bacteria such as Staphylococcus, Saprophyticus, Acinetobacter, and most Enterococci. Limitation of this test are bacteriuria may be present in the absence of nitrite positivity, and it is seen in organisms expressing low levels of nitrate reductase when urine dwell time in bladder is short. Coming to the blood or heme, dipstick urinalysis is able to detect the hemolyzed and non-hemolyzed blood in the urine. The pseudoperoxidase reaction of the erythrocyte free hemoglobin or myoglobin catalyzes the chromogen oxidation on the dipstick to produce a color change. A positive test may be indicative of hematuria from the trauma, infection, inflammation, infarction, calculi, neoplasia, clotting disorders, or chronic infection. Hemoglobinuria may be associated with intravascular hemolysis, burns, sudden cold, eclampsia, sickle cell crisis, multiple myeloma, alkaloids like mushroom, transfusion reactions. Sensitivity of the test for the presence of RBC is 90%. Urinary ascorbic acid interferes with the peroxidase reaction and we may get false negative result. Ketones like acetone, acetoacetic acid, beta hydroxybutyric acid are the endpoint of the incomplete fat metabolism. They accumulate in the plasma and are excreted in the urine. Ketonuria is associated with low carbohydrate, starvation, diabetes, alcoholism, eclampsia, and hyperthyroidism. Ketonuria also associated with overdose of insulin, isoniazid, and isopropyl alcohol. Most urine analysis reagent test utilizes the nitroprusside test, which is most sensitive to acetoacetic acid, less sensitive to acetone, and not sensitive to beta hydroxybutyric acid. False positive test False positive results are seen with heavily pigmented urine, drugs such as captopril, levodopa, salicylate, phenothiazines, and false negative results are seen when negative nitroprusside test for ketonuria. It underestimates the presence of ketonemia due to increased beta hydroxybutyric acid concentration. Glucose is not primarily present in the urine, with less than 0.1% of glucose normally filtered by the glomerulus, so its concentration is less than 130 mg per 24 hour. And glycosuria occur in patients with elevated serum glucose level, that is diabetes mellitus, or in the presence of reduced renal threshold and reduced glucose reabsorption in the renal tubular disease and pregnancy. Glycosuria also associated with certain drugs such as cephalosporin, penicillin, nitrofurantoin, methyl-dopa, tetracycline, lithium, carbamazepine, phenothiazine, steroids, and thiazide. Glycosuria coexist with proximal tubular dysfunctions including phosphaturia, uricosuriasia, renal tubular acidosis, amino aciduria in the setting of normal plasma glucose. Patients using SGLT2 inhibitors may have glycosuria with normal plasma glucose. False positive results are seen with hydrogen peroxide or bleach, and false negative are seen with ascorbic acid or fruit juices. Some dipsticks are affected by increased specific gravity and ketonuria. We should note that dipstick implying the glucose oxidase or peroxidase reaction for screening are specific for glucose, but they can miss other reducing sugars like galactose and fructose and are not suitable for testing newborn and infant urine. Instead of this, we can use modified Benedict copper. I repeat, dipstick implying the glucose oxidase or peroxidase reaction for screening and are specific for glucose only, but we can miss the other reducing sugars like galactose and fructose, and they are not suitable for testing the newborn and infant urine. Instead, here we use modified Benedict's copper reduction test. Coming to the bilirubin, normally bilirubin is not present in urine. Presence of bilirubin in the urine, that is bilirubinuria, can indicate liver disease before jaundice appears. Bilirubin is formed as a byproduct of red blood cell degradation in the liver, which then conjugates with the glucuronic acid and excreted in the bile. Within the intestine, the bilirubin is converted into stercobilin, that is excreted in the feces, and urobilinogen, that is excreted by the kidneys. Failure of conjugated bilirubin to reach the intestine, for example in biliary obstruction, will result in bilirubinuria. Raised conjugated bilirubinemia with bilirubinuria is associated with hepatocellular disease, cirrhosis, viral and drug-induced hepatitis, and biliary tract obstruction like choledocholithiasis, pancreatic cancers, pancreatic causes of obstructive jaundice, for example, carcinoma of the head of the pancreas, and recurrent idiopathic jaundice of pregnancy. False positive results are seen with phenothiazine group of drugs. False negative results are seen with vitamin C, aged sample, conjugated bilirubin hydrolysis to unconjugated bilirubin at room temperature if it is kept for long, rifampicin and exposure to UV light. The UV light converts the bilirubin to biliverdin. Note, only the conjugated bilirubin can be excreted as a bilirubinuria. A positive test for urine bilirubin confirms the conjugated hyperbilirubinemia. Urobilinogen normal level in the urine are zero point 0.2 to 1 milligram per deciliter. They are formed by the bilirubin by the intestinal bacteria. Most is excreted in the feces or recycled into the liver, and a small amount, less than 1%, it is excreted in the urine. Increased urobilinogen levels are seen in cirrhosis, hepatitis, hemolytic anemia, pernicious anemia, infections like malaria, infectious mononucleosis. This test is sensitive but not specific test for liver damage, and especially in patients with hemolysis and severe infection. Decreased or absent urobilinogen is seen in obstructive jaundice and elevated bilirubinuria levels. Charles Krauthammer has said, "Science has everything to say about what is possible. Science has nothing to say about what is permissible." With this, I conclude my today's topic. Thank you. Keep learning.